on massive tears where 17 of 18 tears failed. And we know there's lots of risk factors involved with why these fail, and our job as surgeons is to try to understand who we should be fixing in the first place and what we should be doing. And you've been hearing all the tips and tricks this morning on how to make them do better. Alex Letterman showed various procedures exist, but the bottom line is there's no surgical option that's shown clinical superiority. And patients have to be aware that a lot of these options that you're hearing about will fail. And I think the enthusiasm that we hear at these meetings about the newest and latest technique, and then 2 years later, we're now talking about maybe that technique is no longer as in vogue as it was 2 years ago. So I think it behooves us all to keep in mind that there's a patient on the end of these enthusiastic new techniques every year, and we have to be careful about that. This has been very helpful from our friends in Korea. We heard about it earlier from Tony, the Rohi score. The problem with this score is that you do have to have a DEXA scan as part of the scoring system, and so some other colleagues have shown that there's a modified scoring system that just looks at these 4 variables, and if you have less than 5, repair failure rate was 8.3%, and greater than 5 points, up to 51%. So you might want to use this scoring system as a slightly easier version of the original. So I think you have lots of surgical options, same as for primaries. I actually don't consider the superior capsular reconstruction as an option for me anymore. It's fallen out of favor in my own practice and a variety of reasons. But I'm just going to try to give you a case-based approach and thinking about this from, I think the way we all think about this is a 53-year-old prior arthroscopic repair has failed.